time also they were not analysts.
Yeah, he is joining. Abdul Hakim also. Abdul Hakim is joining. Dr. Rajshekhar has joined, sir.
Yeah, Rajshekhar has joined.
Okay, sir. Please do Dr. Sam.
Dr. Bristow George sir is facing some network issues, sir. So he told he's just keeping on trying. So if he's delayed, like we can start the meeting. So he told he'll join in the middle.
Live on YouTube.
Hello. Front of join ചെയ്യാൻ
രണ്ടല്ല മൂന്ന് ഡോക്ടേഴ്സ് ജോയിൻ ചെയ്യാനുണ്ട്. Only Rajshekhar has joined. Other three panelists have not joined.
ക്രിസ്റ്റോ ജോർജിനെ നെറ്റ്വർക്ക് ഇഷ്യൂ ഉണ്ടെന്ന് പറയുന്നു. അബ്ദുൾ ഹക്കീം ഇപ്പൊ ജോയിൻ ചെയ്യും. വാട്സപ്പ് ചെയ്തിട്ടുണ്ട്.
Uncle, you have to allow Dr. Abu Bakr.
Ankur, are you there? Good. I'll just call up him.
Yeah, sir. Yeah, Uncle, Dr. Abu Bakr waiting in the lobby.
Yeah, I have already given him rights. Now it is.
Yeah.
When to go live?
Yes.
Abu Bakr sir, good evening.
Good evening, sir.
Yes. Hi.
Yes, sir.
Can we go live on audience link?
There is one more doctor. I'll just inform you.
Okay.
Mobile?
You can operate through mobile.
Yeah, you can do Zoom. Zoom is the easiest. All other are difficult. Sometimes you complicated. Zoom is video calls was the Google.
ലോക്ക്ഡൌൺ ശേഷം ഫസ്റ്റ് ലോക്ക്ഡൌണിന് ശേഷം എല്ലാവരും ഉപയോഗിക്കാൻ
അതെ, ഈ വെർച്വൽ മീറ്റിംഗ് ഒരുപാട് വരാൻ തുടങ്ങി.
ഫാമിലി മീറ്റ് ഒക്കെ വെർച്വൽ ആയിട്ട് കണ്ടക്ട് ചെയ്യുന്നു.
അബൂബക്കർ വന്ന് പിന്നെ ഓഫായി.
ഇല്ല ഓഫായിട്ടില്ല, ഞാൻ ഉണ്ട്. ഐ എം വെരി മച്ച് ഇൻ സർ. I can hear you.
Switch on your video.
Video on.
Yeah, but switch on your video.
Video on ആക്കിണ്ടല്ലോ ഞാൻ.
Right. Okay, now it is on. ഇറ്റ് വാസ് ഓഫ് ആയിരുന്നു. നിങ്ങൾ ആദ്യം കണ്ടു കഴിഞ്ഞിട്ട് പിന്നെ ഓഫ് ആയിരുന്നു. ഇപ്പൊ വീഡിയോസ് ആണ്.
ഓ ഓക്കെ. ഞാൻ
ഇടയ്ക്കിടയ്ക്ക് നോക്കണം വീഡിയോ.
ഓക്കെ ഓക്കെ. ഞാൻ മറ്റേ മെറ്റീരിയൽ ഒന്ന് റെഫർ ചെയ്യായിരുന്നു എന്തൊക്കെയാണെന്നുള്ളത്. ഓക്കെ.
Abdul Hakim sir, good evening, sir.
Three are there.
Yes, sir.
അപ്പൊ അയാള് ഉണ്ടാവില്ല ഇത്.
Shall we start, sir? Good evening, sir.
Yeah.
Okay. So, Ankur, you can open for delegates now.
1 minute.
Hakim.
Yeah.
We are live.
Okay. Thank you, Ankur. Thank you. Good evening, doctors. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I am Balaji. Take great pleasure in welcoming all the eminent doctors who have joined us for today's panel discussion. Doctor, today's panel discussion will be on rosuvastatin, titled Galaxy of Experience with Rosuvastatin. Doctor, at Alchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so many times. To navigate through the entire meeting, we have with us today Dr. K. Kunali sir, who will be our moderator for today's panel discussion. Kunali sir. I take pleasure in introducing, giving a short introduction about Dr. Kunali sir. Although Dr. Kunali sir is known doctor for all the doctors in Kerala, Dr. Kunali sir is a senior consultant cardiologist who is practicing at Calicut. Doctor is currently associated with the Heart Center, Malabar Hospital at Calicut. Doctor was head of the cardiology department and medical and executive director, ICRA Hospital Research Center, Calicut. He was past president of several medical associations, and doctor also has been awarded various awards. He was a recipient of over dozen national and state and international awards, including Gandhi Darshan Award, Award, which has been jointly given by Kerala State IMA and Rotary Club. Doctor also was a past president of KSDI, and he was a past chairman of KSDP, and he was a founder and president of Kerala Heart Care Society. With this short introduction, I once again welcome Dr. Kunali sir. Welcome, sir.
Thank you very much, Balaji. And
I just give a short introduction of all the panelists, sir, and I'll just hand over the session to you, sir. It's my great pleasure to welcome all the eminent panelists for today's panel discussion. I'd like to welcome Dr. T.S. Rajshekaran sir. Dr. Rajshekaran sir is a senior consultant physician. Has done his MBBS at Karnool Medical College in the year 1988 and MD in the year 1992. He has completed graduate diploma of in diabetology from Tunda, Australia in the year 2001. Doctor is currently working as a diabetologist and senior consultant physician at IGCH Talasheri. So with this short introduction, I welcome Rajshekaran sir. Rajshekaran sir, welcome sir. It is also to welcome the next panelist, Dr. Abdul Hakim sir. Dr. Abdul Hakim sir is a consultant physician and diabetologist who is practicing at Edapal. Doctor has completed his MBBS in the year 2005, and he has completed his post-graduation in 2013 and fellowship in diabetes in the year 2016. Doctors are currently associated with Edapal Hospital, physician and diabetologist from 2016 onwards. So welcome Abdul Hakim sir. Take this opportunity to welcome our next panelist, Dr. Abubakar Zeshan sir. Dr. Abubakar Zeshan is a senior consultant physician and diabetologist who is currently associated with the Fatima Mata Mission Hospital, Wayanad. Doctor has completed his MBBS in the year 2004 and post-graduation in the year 2008, and is working at the Fatima Mata Mission Hospital for the past 8 years now. Welcome, Abubakar sir.
Thank you.
Taking this opportunity to welcome the next panelist, Dr. Winston Bristow George sir. Doctor is a senior consultant physician and diabetologist who is practicing at Nikhil Hospital, Kannur. Welcome, Bristow George sir. With this short introduction, I'll just hand over the session to Dr. Punali sir. Sir, you can set the context for the meeting. Over to you, sir.
Thank you very much for the kind introduction of all of us. Esteemed members of the panel, my dear professional colleagues in the audience, members of the Alchem team, ladies and gentlemen, we are all extremely grateful to you for giving us an opportunity to be a participant in this panel discussion. We are indeed honored. Friends, 50 years ago, we did not have effective and specific drugs for the management of dyslipidemias. When I had missed infraval-STEMI in 1987, and the coronary angiogram showed total occlusion of the right coronary and 30% lesion in the left circumflex, I was advised angioplasty or bypass surgery by a number of consultants in Riyadh and London. But I prefer to have medical treatment. I was prescribed cholestyramine. I do not know how many of you have seen cholestyramine or know about it. Cholestyramine was given to me 4 grams 3 times a day. And when you take 4 grams of cholestyramine, it's really filling and you won't be able to eat much after that. As a result, you may lose weight, but the lipid levels do not come down remarkably. Decades later, the statins arrived in the market and it revolutionized the management of dyslipidemias. Today, we have a number of statins in the market. The most commonly used is atorvastatin, and the most powerful is rosustatin. Now, rosustatin is rapidly gaining ground. Today, we shall have a detailed discussion on use of statins in the management of dyslipidemias, with special reference to rosustatin. There are a number of studies showing reduction of atherosclerotic cardiovascular disease risk with statin. Now, I invite the magnitude of statin therapy and detail the available evidence with rosustatin. Thank you very much. Abdul Hakim, please.
Hello.
Yes, sir. Hakim sir, you're audible, sir.
Audible?
Yes, sir.
So I just missed the initial section, so I didn't heard about much about what they have talked. So I think they have addressed to talk on the individual experience regarding this rosustatin, and we people I'm in 42, so I don't have much experience regarding this, but as of now, we have a lot of patients, diabetic patients, with a history of triglyceridemia or hyperlipidemia. So the initial thing that's the patients, the almost all studies which we usually get adverse of that, getting patients having more than 14 years with type 1 or type 2 diabetes, we have to start statins. So it's a very difficult thing that with a normal person with a normal lipid level coming into our clinic, whether it is he's a diabetic or not, to convince him that to take a statin. So initially, what I used to tell them that there is, whenever the result, the printed result may be normal to you, but an internal process will be upgoing inside your body. So the main advice by the various studies gives that to start and statin above 14 years, whether you are diabetic or not. So as a diabetic, it's a comorbid condition. It's aggravate the aggregations. So better to take a statin in a lower dose. So the most of studies which we have seen regarding the
Thank you, Becky. Now I have to ask, do you prefer rosustatin or retrostatin for high intensity statin therapy?
Sir,
And why? What is the dose you prefer?
Sir, in my country, this one I'll be using of 20 of rosustatin, a moderate dose. One of the benefits I have seen that here it is the lowering of LDL plus triglyceride and will be the increased level of HDL cholesterol. So I prefer rosustatin instead of atorvastatin. But in some patients, because of the price and all those things, we have to go to atorvastatin.
What is the dose of atorvastatin? What is the dose of rosustatin that you use?
Atorvastatin,
For high intensity treatment.
10 or 20. High intensity, we go for a 40 mg atorvastatin. For primary prevention, I'll always choose 20 atorvastatin.
So atorvastatin 40 to 80 milligrams and rosustatin 20 to 40 milligrams for high intensity
Yes, sir.
statin therapy. Okay, thank you very much. The guidelines regarding drug treatment of dyslipidemias keep coming from number of sources year after year. The level has been progressively coming down over the years, and the dose of statins were being constantly revised to achieve the new goals. Now we use low, moderate, or high intensity statins depending upon the goals we set. Dr. Rajshekharan, could you tell us which intensity of statin you would give to which type of patient? The floor is yours. Dr. Rajshekharan, please.
Yes, sir. The patients with LDL cholesterol above 100 without any ACVD risk factors, we may go for low intensity for the patient who doesn't above the 45 years. And even the diabetic patients with above around 100 milligrams, this LDL cholesterol without ACVD factors, we can go for mild therapy. That is 5 to 10 mg of rosustatin. And if the patient's the risk factors is more than 7.5%, we will go for the high statin therapy, that is 10 to 20 to 40 milligrams. If the rate is that this atherosclerosis disease, the percentage less than 7.5%, we'll go for moderate intensity therapy. That is 10 to 20 milligrams.
In primary prevention for adults between the ages of 45 and 75, with or without diabetes mellitus, what is the incremental risk reduction imparted by moderate and high intensity statins?
This is around
Please elaborate.
There is around 30% reduction in the mortality of the ICVD incidence. When you are using the statins,
Well, now is the era of combinations. We use combinations of two different types of lipid lowering drugs,
one is,
either as a combination single pill or separately,
yeah,
with a view to reduce side effects or for synergistic effect.
yeah,
Sometimes the combination of statin with other class of drugs helps to reduce the pill burden,
yes,
and it helps to increase the compliance of the patient. Now I request Dr. Abubakar Sishan to tell us about the statin combinations and the indications in different types of patients.
Statins. Good
Dr. Abubakar,
evening,
please.
sir. Yeah. Good evening, sir. Yes, sir. So statins are usually used in combination with antiplatelet drugs. We have most commonly used antiplatelet drugs here. We have aspirin and clopidogrel. So we combine statins with aspirin and clopidogrel in case of coronary artery disease, in case of cerebrovascular disease, strokes, infarcts, and also patients with risk factors. Patient who has metabolic syndrome, patients who have risk factors. Usually we combine clopidogrel and atorvastatin or rosuvastatin. Now here, the trend is shifting towards rosuvastatin. As rosuvastatin has more slightly better advantage over atorvastatin. When we use in combination therapy, we can always go for a very lower dose of 5 milligram, 5 to 10 milligram, as compared to the atorvastatin which we use at a higher, we might have to go at a minimum of 20 to 40 milligram when we continuously use. And atorvastatin, as we all know, has some other side effects also. It is contraindicated in reduced GFR conditions in case of diabetic kidney disease, where GFR is less than 30. We'll have to reduce the dose of atorvastatin. So whereas rosuvastatin, we can give safely, comparatively, at a safer dose. And also atorvastatin at higher doses of 80 milligram per day can cause plantar fasciitis and other musculoskeletal involvements. Patients might have difficulty in walking also. So when we use rosuvastatin, we can negate that effect. So overall, we are using combination therapy these days. Of course, as you said, sir, to reduce the pill burden and also to prevent the further complications. Even if the patient has all the metabolic syndromes, it is always better to start a combination of rosuvastatin with clopidogrel or aspirin combination, sir.
even when we need reduction of the LDL cholesterol more than 50%, we can add ezetimibe, which can reduce the absorption of the cholesterol from the gastrointestinal.
Okay.
When there is a additional triglycerides, the rosuvastatin helps better than the atorvastatin. When the HDL cholesterol is little lower, it has got more effect by increasing the HDL cholesterol when compared to atorvastatin.
Are there any other combinations other than ezetimibe and the statins? Any other combination with statins?
Fenofibrate
is being used to reduce the triglycerides in combination of these things.
Any other drug?
Sir, can we use fenofibrate and ezetimibe and
Even
You said
niacinamide
about
can be used.
long duration in fenofibrate or ezetimibe on a long-term duration, long-term basis?
lipid lowering.
Even niacinamide, we can use it to increase the HDL cholesterol. Niacinamide is 500 mg.
niacinamide has been actually, it's almost given up.
Given up.
One, because the long-term studies have not shown real benefit.
Yeah.
Two, because the headache it causes.
Yeah.
So I was not referring to that. You
Even
have
GI
not
disturbances.
mentioned about saroglitazone.
Yeah. Saraglitazone. Yes,
Saroglitazone.
yeah.
Saroglitazone is a good drug.
Lipaglyn.
Triglycerides.
Lipaglyn, that is there.
Yes.
Yeah. That reduces
Yeah,
the
yeah.
triglycerides also.
So that-
Triglycerides.
You can mention for combination drugs, and combinations are now very commonly used, and they are really helpful. A meta-analysis of 29 studies reported by KAN and others in team confirmed that statin reduced mortality in patients undergoing clopidogrel treatment without affecting platelet activation and aggregation. We all know that diabetes mellitus is one of the most important risk factors for coronary artery disease, and the prevalence of diabetes is rapidly increasing to epidemic proportions in our subcontinent. There are experts who feel that every diabetic should be given statin after the age of 40 years, irrespective of their baseline LDL-C levels. Dr. Rajshekharan, do you agree with that? And do we have adequate data to support this claim? Dr. Rajshekharan, please.
Yes, sir. There are elevated effects of rosuvastatin on mean platelet volume also. It is a marker of platelet activity in patients with diabetes mellitus. Even that also is there will be reduced mean platelet volume, and that will reduce the burden of the atherosclerosis and platelet aggregation also.
Now, you had mentioned about the adjustment of the dose of statins depending upon the ASCVD risk score. In your practice, Dr. Rajshekharan, do you measure the risk score in every patient and then adjust the doses?
We need not, if already primary prevention with hypertension and other things, the combination of the risk factors, it already gives us the approximate total risk factors. If the patient is already having 45 years, plus hypertension, plus dyslipidemia, it almost gives us the clue that we need not calculate for every patient. Yes, it is.
Section patients now. Then normal delivery.
Thank you, Dr. Rajshekharan.
Yes.
In the Jupiter trial, rosuvastatin was used. The results indicate that use of rosuvastatin is associated with significant reduction in the major cardiovascular events, including death, in apparently healthy individuals with LDL-C below 130 milligrams per liter. So it's a good drug to give for primary prevention. Now, Dr. Abdul Hakim,
ഞാൻ എന്താ വരുന്നു പറയും ഫാൻ എടു ഫാൻ
yes. What is the evidence for secondary prevention of major cardiovascular events with 7 different statins?
30 to 40% of reduction was noticed when rosuvastatin was preferred over pravastatin and other statins.
Yeah, you are right. Now, in the secondary prevention trials, the mortality was reduced by 12%. Major cardiovascular events was reduced by 13% by pravastatin and 41% by atorvastatin. In indirect comparison with network meta-analysis showed that rosuvastatin was better than atorvastatin in the prevention of major cardiovascular events. 2019 CCHA guidelines on primary preventions of CVD. According to that, what are the recommendations for statin treatment according to the 2019 ACCHA guidelines in the different age groups? Anybody? Any one of you? Between the age of 20 and 75 years, LDLC level more than 190, high intensity statin without risk assessment.
Yes,
Diabetes,
here we can give high dose of rosuvastatin when for a younger age group
those
on a
with
longer duration.
and the age between 40 and 75 years, moderate intensity statin.
Yes.
And high risk patients, high intensity statins.
Yes. Yes.
Age
Yes.
above age of 75, clinical assessment and risk.
Low dose.
Between 40 and 75, LDLC between 70 and 190 without diabetes, and the risk 5 to 7.5 plus risk enhancers, moderate intensity. Now we shall move on for the discussion of atherosclerosis regression. Until 3 decades ago, doctors believed that atherosclerosis regression was a myth and not a reality. Today we have sufficient data to prove atherosclerosis regression is a reality. Dr. Abubakar Sisan,
Yes,
what
sir.
is your opinion regarding the regression of atherosclerosis, which therapy induces maximum atherosclerosis?
I think you have been in the forefront of promoting, sir. Yes, sir.
Yes.
I think you have been in the forefront of promoting the idea of plaque regression since past 2 to 3 decades all over India, in fact. And many of the cardiologists, your contemporaries, had differed from your views. And the recent studies have come to prove that what you have been saying all along has been true and is turning out to be the way of approach going forward. Yes, sir. Can you hear me, sir? Hello?
Which statin induces maximum atherosclerosis regression, and what is the evidence for rosuvastatin?
Rosuvastatin at a very lower dose than atorvastatin gives a better plaque regression on a long-term basis. The new evidence are suggesting that rosuvastatin gives better plaque regression as compared to atorvastatin, and it is much safer on a long-term basis.
Thank you very much. You are right. In the Meteor trial, rosuvastatin delayed the progression of carotid atherosclerosis in those with subclinical atherosclerotic lesions. And significant regression of atherosclerosis was seen with 40 milligrams per day in patients with established coronary heart disease in asteroid trial. Rosuvastatin induced carotid regression in inflammatory joint disease and was reported in 15 in patients with rheumatoid arthritis and ankylosing spondylitis. In a study reported in 2015 by John Mustard in International Heart Journal, intensive lipid lowering therapy with ezetimibe and rosuvastatin showed significant incremental reduction in coronary plaques compared with usual dose of statin therapy. That is the usual dose of statin therapy of rosuvastatin 5 milligrams ezetimibe. When the dose, better results. Well, now we know that cardiovascular events continue to occur due to reduced residual risk in high-risk patients in spite of achieving LDLC goal of 70 milligrams per deciliter. Now, what is the ideal level of LDLC for best results? Dr. Ashish?
It is It is a 50% reduction of the original levels. And the restricted risk is more. We have to go up to the LDL level up to 70 or below.
Up to
70 or below.
now, if you remember the old ATP guidelines, and if you remember the graph that showed, and if you look at the graph very carefully, this is 1.4 at 70 milligrams, and the risk drops to 150 milligrams. So, especially in high-risk patients, the present goal is 50 milligrams, not 70 milligrams, to get the best results. Now, there are studies to show that rosuvastatin may induce rapid and lasting decrease in the carotid plaque lipid content and plaque regression as assessed by MRI. Dr. Zhishan,
Yes, sir.
can you elaborate on this topic?
Yes, sir. Plaque regression on a long-term basis of rosuvastatin on the carotid and arteries, there is definitely regression over all the major vessels, not only coronary arteries alone, even other major vessels. There is a reduction in the plaque by at least 30 to 40% over a period of use of at least 6 months to 1.5 years. And on long-term basis, we can sustain the plaque reduction.
We all know that statins have multiple pleiotropic effects, including plaque stagnation, anti-inflammatory effect, antioxidant effect, improving endothelial function, and hemostasis. Rosuvastatin significantly reduced, as mentioned by Dr. Rajshekhar, mean platelet volumes. Dr. Abdul Hakim, what are the clinical implications of this? Or anybody else?
Sir, continuously, when monitored for more than 6 months, there was a definite reduction in the LDL-C levels, and also the overall lipid parameters were reduced, and there was lower events of coronary artery disease, and major cardiovascular risk factors had reduced over long duration use of rosuvastatin as compared to other statins. And it was safer also.
That's right. There are now studies to show that rosuvastatin can reduce arterial stiffness. Now, the question is for Abdul Hakim. Is it specific for rosuvastatin or can it occur with other statins?
According to this Galaxy study, that is low dose rosuvastatin would be more effective in improving the arterial stiffness. And high risk patients with dyslipidemia, the result suggests that improvement of arterial stiffness by rosuvastatin mainly depends on its strong lipid lowering effect. So it was 20 to 40 mg daily showed a progressive reduction in the brachial angle pulse, that is wave velocity, with a decrease the low density lipoprotein cholesterol and high density lipoprotein cholesterol, L and H ratio. So the high sensitivity of C-reactive protein and the changes in the PVF correlated significantly with that of L and H ratio and that of CRP after rosuvastatin treatment. This is the Galaxy study regarding the treatment effect of the rosuvastatin on arterial stiffness.
We have already covered most of the important aspects of statin for management of dyslipidemia. And before I conclude, I would like to invite questions from the audience. Any questions from the audience, please?
Sir,
There are no-
regarding the safety of rosuvastatin compared to atorvastatin, hepatic and renal safety, what do you feel, sir, according to your long-term use of atorvastatin? And now you, after arrival of the rosuvastatin, you have been extensively using both products. Which one do you feel is better in preventing or progression of diabetic kidney disease? And also, which is better in patients with chronic liver disease?
Now, this is a very good question. Answer. I do not know how many of you remember when rosuvastatin was introduced to the market first time. There were some pamphlets coming in saying that rosuvastatin results in death due to rhabdomyolysis, and so it should not be given. As a result, rosuvastatin went out of the market for several years. That is the reason why the reintroduction was late. But it was found that if you go beyond 40 milligrams per day, then only you get rhabdomyolysis and problems. If you go to 40 or less, it does not really matter. And regarding your kidney function, now when you are giving any of these drugs, you monitor the liver function and the kidney function. And if you, for the liver function test also, many believe that SGOT, SGPT goes more than double, then you may have to discontinue for some time or reduce the dose. Otherwise, a little increase in the SGOT or SGPT, there is no reason to change the drug. And so both with atorvastatin and rosuvastatin, you monitor the kidney function. If the kidney function doesn't worsen, you continue with the same. And some patients develop severe myalgia. And if that happens, you reduce the dose and see. And if it continues, you may try pitavastatin. Some patients with pitavastatin do not develop myalgia and certain symptoms. So you can, if you carefully use these drugs, you don't get into trouble. If you carelessly use, yes, you may get into trouble. Now, before I sum up and conclude, if any one of the panelists would like to make a comment or give any additional information, you're welcome.
Sir, can I ask a question for you, sir?
You're not supposed to ask me a question. Doesn't matter. You can.
Sir, nothing that, sir. The type 2 diabetes patient with hypertriglyceridemia, by giving a combination of rosuvastatin with fenofibrate, once it's not comes down, so what is the other alternative we have to do, sir?
Said Saraglitazar not only brings down the triglycerides, it also helps to control the diabetes. So saraglitazar is a definite choice, and I very often use saraglitazar for my patients. Anybody else would like to say anything? To sum up and conclude, now we all know that aggressive rosuvastatin treatment results in halting and regression of atherosclerosis in the carotid and coronary arteries respectively. Rosuvastatin reduces oxidized LDL levels, which is an independent risk factor for cardiovascular disease in patients with dyslipidemias. High dose and low dose rosuvastatin treatments reduce the volume of lipid-rich necrotic core and contribute to plaque stabilization. Rosuvastatin decreases mean platelet volume, which is a determinant of platelet activation. Rosuvastatin also reduces arterial stiffness. Friends, it has been a very interesting and informative panel discussion. All the panelists have contributed immensely for the success of today's session. I congratulate all the participants. So now that it is very clear that
angiotensin 2 to angiotensin 1-7. So naturally, when ACE2 is downregulated, because it is attached to the SARS-CoV, the angiotensin.
Oh, hello. There is a disturbance. Please mute your audio. Rosuvastatin is undoubtedly the most powerful statin. And as already been mentioned by Dr. Zishan, I have been educating atherosclerosis regression for over 3 decades. And initially when I started talking about it, I was made fun of. I was criticized all over by my friends, my colleagues, by my seniors and everyone. But today we know that it is a definite reality and not anymore a myth. One of my first cases, about 16 years ago, a patient who went to a multi-specialty hospital in Kannur with mild angina. The angiogram showed total occlusion of the anterior descending and minor lesions in the other vessels. They tried to open it up. They tried 3 times, 3 occasions at weekly intervals. Then they were not able to get across the block. Initially, when he went to the hospital, he was mildly symptomatic. But after 3 attempts of poking the blood vessel and damaging the blood vessels, he became very unstable. He was in unstable angina. So he was told that he should have immediate emergency bypass surgery. He came to me at that stage. Because he was overtly very obese, an young man, 44 years old. So I kept him in the hospital for 3 weeks. And he lost about 10 kilograms. And with optimum medical treatment, he became asymptomatic. He went back to Saudi Arabia, came back to me after 2 years for checkup. We did the angiogram, and to our surprise, the 100% block, which they could not open after 3 attempts, had opened up. It was only 80%. So that was the first clue to me that I've been able to prove what I said. So since then, I've been able to have atherosclerosis regression of varying degrees, from 50% to even 100% over the last 20 years. So let me tell you all that atherosclerosis regression is a reality and not a myth. With therapeutic lifestyle change and optimum medical treatment with a set goal for every parameter, if you achieve that, you can achieve atherosclerosis regression. So friends, thank you very much for your kind attention, and we are extremely grateful to you for giving us an opportunity to be a part of this panel discussion. Thank you all. Special thanks to my panelist colleagues.
Thank you, sir.
Thank you, sir.
Thank you very much, sir.
My pleasure to propose a vote of thanks today. Firstly, I'd like to thank the moderator, Dr. Punali, sir, moderating the panel discussion today. It was a good meeting, a complete discussion on statin, and all possible of descriptive treatment has been covered. So thanks for all the inputs which you have provided for all our doctors today. Thank you, sir. And I'd like to thank all the panelists, Dr. Rajshekhar sir, Abubakar sir, Dr. Hakim sir, for sharing your inputs and sharing a clinical experience on rosuvastatin, which will be more helpful for all the panelists who are attended today. I'd like to also thank delegates who have joined us for today's panel discussion, and I'm sure all the doctors will appreciate the views which has been presented by all our panelists regarding rosuvastatin. And at this juncture, sir, we like to salute all the doctors and paramedicals who have contributed immensely for keeping us all safe and healthy in these challenging times. Sir, we at Alchem will continue to serve doctors and patients by making our products available, especially our Jupilos, Goldcom, and Blue Vilda. So, yeah, thanks, sir. I'd like to once again thank for giving us an opportunity for this panel discussion. Thank you, sir, and good night, sir.
Good night.
Thank you, sir. Thanks, Rajshekar, sir.
Good night. Good night.
Sir, thank you.
Hakim hai? Dr. Hakim? Okay. Anyway, good night. Thank you, everybody. Once again.
Okay, good night.
Good night. Bye.
Thanks, sir.